Savage. I'm the Director of Pharmacotherapy at the Mountain Area Health Education Center in Asheville, North Carolina.
I'm Molly Scott. I'm the Regional Associate Dean for UNC Eshelman School of Pharmacy, and I also practice as a clinical pharmacist practitioner at Mountain Area Health Education Center.
Hello, I'm Elizabeth Michelet, Regional Assistant Dean of Clinical Affairs for the UNC Eshelman School of Pharmacy and a pharmacist at Mission Health System in Asheville, North Carolina.
So in the legislature, there is a bill in the House and in the Senate that would allow pharmacists to have what we call provider status. And this would list pharmacists as providers under CMS, so under Medicare. And what this would do for pharmacy, there are a number of things that I think are incredibly positive about this bill. It changes the way that reimbursement occurs, and so billing for pharmacy services would now be something that we would be able to do and bill at the level of service provided. And so
I'm really excited about the provider status legislation because I feel like this is something that our profession has needed for a long time, and it would really help to advance what we do and increase the recognition of what the pharmacist can bring to the healthcare team, and certainly also creates a payment mechanism because reimbursement for cognitive services has been a barrier to expansion of innovative ambulatory care models across the country.
Clinical pharmacist practitioners, or CPPs, which is a license that pharmacists can get that allow them to prescribe, initiate, titrate, discontinue certain medications, also draw labs that are important for patient care. I manage a department of 5 clinical pharmacist practitioners, so all of my pharmacists are CPPs. And what that allows my department to do is really manage patients in a different way. And so a lot of my pharmacists work in the ambulatory care or primary care setting, so they work in a doctor's office and they're seeing patients with chronic disease. So they're managing patients with diabetes, with high blood pressure, with cholesterol issues, with osteoporosis, chronic pain, many chronic diseases that our patients face. My license is mostly related to anticoagulation and management of blood thinners for patients in the outpatient setting. And so we have a primary care clinic where I would see patients and manage their blood thinners to make sure that we're decreasing their risk of clots, strokes, while at the same time decreasing their risk of bleeding, which is a complication that can be associated with these blood thinners. So it requires some continual monitoring, adjustment, and that's what we do in the outpatient setting.
I have been a family medicine pharmacist for almost 20 years and have practiced as a clinical pharmacist practitioner since the legislation was passed. I've worked in many different clinics in family health centers, and most recently am working in pharmacotherapy clinic and in osteoporosis clinic. So our osteoporosis clinic is a clinic that focuses on patients who have abnormal DEXA scans who are coming in to be evaluated for their risk for fracture. And we have a team of people who work together, including a nurse, a physician, and a pharmacist. And we are there to tune up patients' medications and make sure that they're not falling and make sure that we're doing everything for them to keep them from having a fracture. So my role in that clinic is to do a complete medication review to assess medications that might cause falls and to make recommendations and sometimes changes to their drug therapy to get them off medications that might make them fall, like benzodiazepines or tricyclic antidepressants. We also do, as a pharmacy team, a review of diet and supplements for calcium to make sure that they're getting adequate calcium, and also make recommendations to the patient about changing vitamin D dosing to ensure that they're meeting American Geriatric Society guidelines. And then we help with choosing a medication for treatment of their osteoporosis, whether it's a bisphosphonate or teriparatide or denosumab and others. And we go in and we implement that plan and make sure the patient knows all the changes that they're going to be making for that day.
I have been a hospital pharmacist for nearly 25 years and a clinical pharmacist practitioner, a CPP, since 2001. I've been told that I was the first inpatient CPP in North Carolina. By far, the majority of CPPs are practicing in the ambulatory care setting. However, I'm here today to talk to you about and describe for you a couple of practice models for inpatient CPPs. At Mission Hospital, our critical care teams are interdisciplinary in nature. The critical care team consists of the trauma surgeon, the bedside nurse, the pharmacist, and the respiratory therapist, and we work as a team to ensure the best outcomes for patients. The CPPs in this setting play a major role in pain, management of pain, management of agitation and delirium, treatment of healthcare associated infections, prevention of DVTs, electrolyte replacement, glycemic management, and evaluation of patients' home medications, which ones should be continued during their hospital stay, which ones should be discontinued, and prevention of drug interactions.
I think for us, it would enable us to be able to provide the services that are most needed for patients and that are most needed for population management with healthcare reform, instead of relying on certain types of visits that we know are going to help to create financial sustainability models. So it would open up the opportunities for us to do more things than what we're already doing. Now, for other parts of our region in Western North Carolina and across the state and even across the country, I think what it would do is open up doors for practices to hire pharmacists who have never had pharmacists before. Payment is the number one barrier to having pharmacists incorporated into patient-centered medical homes, and so I think that having recognition as a provider with a sustainable model, it would enable practices to be able to hire pharmacists and for pharmacists to be able to do the work that we are already trained to do.
We published a study in January 2015 in the American Journal of Health System Pharmacists, collaboratively with the Director of Trauma Surgery and Critical Care Medicine, Dr. Bill Shillinglaw, describing our outcomes from a 2-year expansion study of the CPP model. And in that study, we saw over 2,100 patients over a 2-year time frame, which included over 13,000 medication encounters. And with the expansion of the CPP model, we observed a 75% reduction in prescribing-related adverse drug events for patients, along with a 37% reduction in adverse drug events that were of higher severity. Along with the CPPs improving safety outcomes for patients, we also observed nearly a $2 million cost savings. And I think it's important to examine the business model for a pharmacist in an inpatient setting. Our business model is that all of the charges and accounting for the time that a pharmacist spends with a patient is really focused on dispensing the medication product, and there's really no room in terms of time compensation that the pharmacist spends at the bedside with the patient and with the team providing disease management services for a patient. So we do feel like the dispensing and the medication product are the foundation of what we do, and is important, but it's really not built into justifying the pharmacist's time, the extra time that it takes to ensure that the patient is receiving safe and effective drug therapy, and the drug therapy management contributions that a pharmacist makes for a patient while they're in the hospital. I think it's interesting that we've done a study internally looking at how many medications patients are on when they do come into the hospital. And last year, looking at nearly 1,000 patients, our patients are on a median of 10 medications per patient. So if you think about the importance of our aging population across the country and the fact that patients are on even a median of 10, meaning there's some patients that are on more medications than that, some less, the complexity of medication regimens, it can be very challenging for the healthcare team, and a pharmacist is needed.